Greetings, everybody. Kevin McFarland here. Thanks for joining me again on the podcast. Wanted to start the podcast a little different this time. I wanted to start with a couple shout outs. Wanted to give a shout out to my friend Bill Barrett, who's a nursing student who listens to the podcast. He was nice enough to send me a comment and tell me how much he enjoys the podcast and how much it's been helping him as he gets through his last couple clinical shifts. I wish you luck, Bill. You're going to get past that NCLEX and be a nurse before you know it. The second shout out is to Jennifer Stafford, who is a clinical nurse educator who left us a nice comment on iTunes. She was the first comment posted in iTunes for the podcast. At some point, I'm going to have Jennifer on as a guest. She would be super entertaining. So again, thanks, Jennifer. Remember, if you haven't done so already, please leave us not only a rating in iTunes, but a review as well. The reviews are what help other people find this podcast and makes it more discoverable to nurses looking for interesting podcasts to listen to. Go ahead and leave a review, and you may be the next person shouted out on the podcast. My guest today is an emergency nurse practitioner who knew that ER was his calling from the days when he was a paramedic. I hope you enjoy today's podcast with Andrew Bowman. First I'm going to do is ask you to introduce yourself. Tell us who you are, tell us your credentials, and what you do now, and a little bit about your background.
Okay. So I'm Andrew Bowman. I'm currently an acute care nurse practitioner working in emergency. I work for a contracted emergency physician group. We cover 3 different community-sized hospitals in the Midwest. The advanced practice providers, the PAs and NPs that are members of the group, work in 2 of the emergency departments. The third one is a freestanding ER that doesn't quite have the census built up yet to require a advanced practice provider helping out. So we work in 2 of the 3 centers that we cover. Basically started out 1982 as an EMT, and then quickly became a paramedic, and then graduated nursing school from Purdue University in 1991, and have always worked EMS and emergency department nursing and medicine ever since 1982. There was quite a bit of a lag time between graduating from nursing school to starting and finishing my master's from my nurse practitioner. I graduated with that in 2007, and ever since then I've been working as an NP in the emergency department, and have had ups and downs, but overall it's an enjoyable step that I've taken.
Nice. So what made you decide to get into nursing? So you started off as an EMS in EMS and as a paramedic. Why the jump to the other side of the gurney?
As I jokingly tell people, I prefer climate control.
Understand.
Yeah, I mean, I was, working in Indiana. It's brutally cold in the wintertime. It's horribly hot and humid in the summertime. And I enjoyed the emergency care aspect of things, but I was really getting tired of slogging myself in and out of rain and snow and heat and humidity. And I still wanted to take care of patients who were experiencing emergencies, but really wanted to stay inside. And so nursing seemed like a nice natural progression.
Nice.
So there was Purdue was in my hometown, and they've got a very good school of nursing, and so got in and on from there.
And at what point in your career were you like, okay, I made the right choice. This is exactly what I'm meant to do?
I think still back when I was a paramedic. I'm not going to, fool anybody and say, I was the uber grand paramedic of them all. I made mistakes, but I felt like I did a good job, and I enjoyed what I was doing. And I enjoyed not only the decision-making process of forming a pre-hospital or field diagnosis, and that's not a bad word, EMS personnel do form a diagnosis.
Absolutely.
And even though a lot of people disagree with that, but also then the procedural side of things, doing the advanced procedures, intubations. I worked for a service where we could do central lines. This is way back before, IOs were the common access for patients you couldn't get a line in. So we placed central lines. We did intubations. And then by working out of a hospital-based service, working in the emergency department, we weren't out on calls, got trained to do other things, like do chest tubes and things like that. In fact, one day a neurosurgeon allowed me to place an intracranial monitor on a patient. So
holy cow.
Had a lot of good mentors and had a lot of fun, and realized, back when I was still a medic, that this is what I want to do.
That's awesome. I think for many paramedics, they find it a natural transition from the EMS side of the house to emergency nursing, and they make fantastic emergency nurses. The hard part is they got to get through nursing school.
Yeah,
that was.
I would agree with that, because there was a paramedic in my nursing class who failed miserably. And I think it was due to came into the attitude of, well, I'm a medic. What are you going to teach me?
Absolutely.
And he didn't take the opportunity to learn, to know what he didn't know. And he was gone quick. When I went to nursing school, the only person who knew going out, first getting started, was my admissions advisor. She knew that I was a paramedic. But I didn't tell.
Kept it quiet.
My instructors kept it quiet.
That's
Eventually,
funny.
Of course, they find out, because you go to clinical sites, which are the hospitals you work out, and everyone knows you. And it's like, well, how do they know you? So, I'm a medic here. And so, it gets out. But I didn't go into class and say, hey, I'm a medic. Can't teach me anything. I went in with the attitude of, I'm a medic, and I have my skill set and I have my experiences, but there is so much more to learn.
Absolutely.
And because of that attitude, I got to do some things that at the time, my nursing student colleagues didn't get to experience, because they were doing the basic skills that I had already learned years before. It was just a good opportunity to take that attitude to, let them find out on their own what I can and can't do. And from that, I was able to do a lot more things than most of the students were allowed to do.
Absolutely. When I was in nursing school, on my first term, there was a young lady I was an EMT, and I was an EMT instructor at the community college where I was going to school. So that was a little bit awkward. But we had a paramedic who was in the class, and one day they were going over vital signs, and they were talking about blood pressures, and they were talking about, getting vital signs. And I'd say 99% of it was like yeah, okay, I already know all this stuff. But there were a couple things, and I don't remember exactly what they were, but there were a couple things that I was like, I did not know that. That fills in a little bit of a blank that I had, and I had no idea. So I was like, okay, I'm going to pay attention and listen here. And the young lady that was in class with me was like, I remember telling one of the instructors, she's like, well, me and Kevin, we're EMTs, so, we already know all this stuff. And I'm like, oh, you keep me out of this.
Don't throw me in there.
I'm here to learn, and this isn't EMT school, this is nursing school. And that's exactly what the nursing instructor said. She said, this is nursing school. It's completely different. And it really is. Very complementary skill sets, but completely different.
Oh, sure. What I remember, probably one of the funniest moments, that kind of ties into this in nursing school. So, med-surg year at Purdue, that was our junior year, where we did a whole year of med-surg nursing. Mm-hmm. And that's where they learned, how to do IVs and things like that. So, one of the first classes of the semester, there's 30 of us in this classroom. We're talking about different types of IV access, butterflies and angiocasts and things like that. And it's a 3-hour lecture session in the morning, and the first hour is just all talking about the different kinds of IVs. And during the break, the instructor goes, now when we come back, I'm going to take this half of the room, and Andrew's going to take that half of the room. I'm going like, wait, what? I'm going to do what? He goes, well, you do this all the time, don't you? I said, yeah. Well, then teach us. I said, okay, well, do I get paid?
Right. Right?
She just laughed. She just laughed at me. She thought, no.
She's like, oh, you're cute. When we were, our IV training included a video about the potential dangers of an IV, of initiating an IV, a demo where the nursing instructor tried on an IV arm unsuccessfully to get a flash, of course, and did a kind of half-hearted IV, and then said, "Okay, now pair up and go practice on each other." And she's like, "You'll be fine." And I was like, going, "Yes, I will be fine, and my person that I'm with will be fine. Everyone else, oh, I don't know, not so much." So sure enough, we go off, we do it, and it was one of those. It was like the end of the day, and they're like, "Okay, as soon as you successfully get an IV, you get to go home." And I was like, "All right, guys, I'll see you later." And I ended up sticking around and helping a couple people get theirs that needed some help, and that was nice. But my fourth semester of nursing school, one of our clinical days, we had kind of a slow clinical day, and there was something going on. I think that there was like some kind of hospital inspectors in the house or something, and the nursing unit was like, "Oh, let's just kind of have the students just stand down for a few minutes." So my clinical instructor, who I just adored, was like, "Hey, do you guys want to practice IVs? Do you guys want to learn how to do that and practice that?" And I was like, "Oh." Everyone was like, "Yeah, sure. Yeah, that'd be great." And she goes, "Great. Kevin's going to teach you." And I was like, "All right, let's do this." I mean, I taught it. I was teaching it in the EMT level all the time. So it was, certainly easy for me to teach. And, we sat there and spent an entire clinical shift practicing IVs on each other, which was good for them. Not so good for my arms, but it was good for them.
Right.
So that's cool.
Yeah, I sacrificed my arms a lot over the years. So
no, yes, more times than I care to remember. Tell me about a patient who changed the way you practice.
A patient that changed the way I practice. That's a tough question, Kevin.
It is a tough question. They get tougher. There's some easy ones, but they're kind of like this.
I mean, because 37 years, there's been a lot of patients. Patient that changed my practice.
What's one that stands out to you that whenever you see a new nurse, you're like, "Hold up, let me tell you a little something that I learned the hard way," that maybe you learned from a patient?
I guess there's no one single patient, but it's just maybe an amalgam of patients over the years that you can't go in with a bias when you're approaching your patient. And God knows we're all guilty of that to some degree at some point or another, me especially.
Oh, it's really hard not to do.
Yeah. You see your frequent flyer and they're there for the same thing that they were there for 2 days ago and 5 days ago and 10 days ago and 20 days ago. And you're
like, "Hi, Bob."
You're rolling your eyes. and so, that type of patient, maybe not a singular patient, but that type of patient has taught me well to, take 10 or 15 seconds in the privacy of your dictation room or where we have to be and just go, "Oh, frick, frack, why are they here?" But then take a deep breath, grab the chart and walk in the room and say, "Hey, Jim, Andrew, nurse practitioner, what's going on today? How can we help you?" And just go in with like you have new eyes, like it's a fresh set of eyes looking at this person. And some days it's hard, and some days I still fail at that. But to try to remind yourself every single time that this might be the one time there's something really bad going on, and you're going to miss it if you don't go into the idea that each time they come in, there's potential that this is the real thing. This is something bad this time. And it's not just the run-of-the-mill, "I'm here because I've got nothing else to do on a Tuesday" reason to come to the ER.
Have you ever been burned by that?
Oh, yes. Yes, I have. Had a guy that, we see a lot and came in with his usual complaint of his chest hurting. and we were a little slow at getting things, getting the IV, and he was having a STEMI. Fortunately, fortunately he recovered well, did well, but our metrics on that guy weren't so good. We were slow on the EKG, we were slow on the IV. Obviously, as soon as we got the EKG, we saw what was going on, but, it was one of those, Jim's here, and of course that's a euphemism. Jim's here for his chest pain again, and we'll get to him when we get to him, and I'm glad we got to him.
Yeah. It's kind of funny when, someone goes back and looks at it, they're like, hey, why did it take so long to get the EKG? And you're like, because it's Jim. And they're like,
because it's Jim.
And they're like, I don't know. Well, someone may say, I don't know what that means, but someone else might be like, I get it.
Yeah. And it's not going to be if that went to, if he had a bad outcome, obviously he lost a few more myocardial cells in that delay, but if he'd had a bad functional outcome and he decided to sue, there's no defense.
Absolutely.
Someone would say, isn't your metric, Mr. Bowman, 10 minutes for an EKG? Yes, it is. But you were 20 minutes? Yes, we were.
Yep.
So yeah, there's no defense.
Yeah. Here's another tough question for you. Tell me about your first medical error, or first either medication or error, patient error.
This was back in the day when there weren't as many cross checks and balances as nursing does today. But I had ordered, this was as a nurse practitioner. And as you know, with electronic health records and, ordering stuff in electronic health records, sometimes little glitches happen. One of the most interesting things that often happens with the records that I'm used to using is sometimes the tracker, the list of patients, you got this long line of patients that scroll in front of you.
Uh-huh.
You go to click on one, and you click on it right at the same time the computer refreshes.
Oh, yeah, I hate that.
And you actually click on a different patient than what you had originally intended. But you don't realize it because you think you clicked on Mr. X when actually you selected Mr. Y. And in this case, Mr. X needed some insulin.
Oh boy.
And Mr. Y, who did not need insulin, got insulin.
Holy
and
cow.
it wasn't discovered until after he had received it.
Oh, wow.
Let me rephrase. This was probably not my first error. Okay, this is a big error I recall
Gotcha.
working as an NP. Probably not going to be my first error ever. I can guarantee that.
Yeah.
But once I realized, of course, there's a mad scramble. Call the nurse, find out. Oh, they've already given it. Okay. So you walk in the room and you say, hey, here's what happened. I was attempting to order this medicine on this patient. Unfortunately, it got ordered on you. And because of that, we've got to do some stuff. I got to watch you. I got to check your blood sugar every hour. Here's something to eat. And he wasn't even diabetic, so it probably wasn't going to be a problem.
Yeah.
But still, it's an error, and you got to own up to it.
That's a tough conversation to have.
Yeah. You got to walk in hat in hand and say, hey, I screwed up. And in your situation, it's probably not going to be dangerous, but there's always that potential. It's going to add to your length of stay. Previously you're probably going to go home here in about an hour. Well, now you're not. So yeah, but you've got to own up to what happened, and you've got to, apologize for the mistake. You have to explain how the mistake happened. And I think if you're honest with these people quickly and upfront about it, they're going to be okay with it. Every time I've had to take that approach, if something has happened, got a wrong test ordered, got a wrong procedure ordered, like an X-ray or something, got ordered on the wrong thing or ordered it wrong. You just say, hey guys, I made a mistake. More often than not, nothing bad is ever going to happen because of it, other than it adds to your bill a little bit, and that usually gets written off anyway. But you just go and have to explain to them, here's what happened, here's how it happened. Probably not going to be anything bad for you, but we're going to make sure, and you go on from there.
the first med error I ever made. I realized I made the med error, and I went and talked to one of the doctors about it, and I was like, "Hey, I got to tell you what just happened." And she's like, "Okay, you got to go tell the patient." And I was like, "What? Excuse me?"
Yes.
And she's like, "This is what we do for medical errors, Kevin. We got to tell the patient." And that was one of the most awkward conversations I thought I was going to have. The doctor walked me back to the patient. And as I was getting ready to say, "Well, here's what we did," she kind of jumped in, swooped in, had the conversation, made the conversation sound like it maybe wasn't an error, but maybe wasn't the best choice of medications. It was putting Lido with Epi into a digit for a digital block. And she said,
which we now know probably isn't a big deal, but at the time.
At the time, we were like, I was afraid I was going to make this guy lose his finger, and the doctor, was like, "Hey, this is probably not a big deal, but we don't really know for sure." So she went back there and she's like, "Hey, here's the deal. We usually don't use this medication we used on your finger. We usually don't use it on fingers. That's why it's really white like it is. But we're just gonna kind of keep an eye on it for just a little bit, and I think we're gonna be just fine." Yeah. And I was like, "Oh my God!" But after that, I'm hyper vigilant. After that, holy cow!
Yeah, one thing I remember a little more recent. It wasn't exactly an error I made, but it was an error made on my patient. Woman comes in with anaphylaxis. Although she wasn't hypotensive, she was just, beet red, a little wheezy. So I ordered, all the usual stuff, some fluids, some IM epi, some solumedrol, some ranitidine, some Benadryl. And, she was doing fine. And, the nurse is going off to do that. And I'd actually gone to get a chart for another patient to go see. And I happened to swing through the nurse's station to talk to the nurse of this new patient I'm getting ready to go see, and the monitor starts alarming. I look up and I see runs of SVT and then a short run of VTAC and then back to SVT. I thought, what the heck's going on? And it's my anaphylactic patient.
Oh my, oh no.
And so of course I run back into the room, and, the patient is kind of like, all wide-eyed, and she's sweaty, and, the nurse is standing there, and I said, "What happened?" She goes, "Well, I gave the 0.3 of Epi IV."
Oh, no.
I said, "That's supposed to be IM." And, of course, went back real quick, checked. Yes, it was ordered as IM, but the nurse, for whatever reason, thought it was IV just because she thought maybe the patient was sicker than what she probably actually was. And so the patient had a little Epi-induced arrhythmia because of that. She did, in the end, she did fine. But again, it's like, this is a medicine we use, and sometimes we can use it intravenously for your condition.
For you.
You just didn't need it this time, but you still got it that way. And she ended up staying with us for a while and getting troponins and EKGs and things like that. But, it reversed her anaphylaxis, that's for sure.
Well, certainly. Now here's the question I have for you. Did she use the cardiac epi, or did she use the anaphylaxis epi?
It was 0.3 milligrams.
Okay.
Of the 1 to 1,000.
The 1 to 1,000. Okay. Because we had an epi patient a while back when I was a charge nurse, and I remember the nurse calling me and saying, "Hey, it says to give this IM, but I just can't figure out how to get this ampule so I can give it IM." And I was like, "Oh, stop. Don't." She was, telling me this on the phone. I'm like, "What? Stop what you're doing. Don't touch anything. I'll be right there." So I was sitting there thinking to myself, I could just see her trying to figure out the ampule of how am I going to give this IM? And I was like, "Oh no, don't do that." But she'd never given it. She'd never given it IM. She'd never given it for anaphylaxis. She'd never seen anaphylaxis. This is an experience. This is a good ER nurse, but she just never seen it.
Yeah.
And I was like, holy smokes, that could have been an error there. Andrew, tell me about a patient who touched your heart.
There's been a lot over 37 years.
I bet.
Back when I was a paramedic, we were a hospital-based service. We did 911 response, but we also did interfacility transport of both emergent and less than urgent transfers. And one of the routines we did was the hospital I worked at did not have the radiation therapy machines for cancer patients. I was at a hospital across town, although both hospitals admitted patients with cancer. And there was this young guy who was probably in his early 40s who was diagnosed with a horrific cancer. So he's a younger guy, probably even now, he probably wasn't even in his 40s yet, because he had a young family, young wife, young kids, and diagnosed with this horrific, it's going to kill him cancer no matter what we do. But by God, we're going to try and fight against it. And, 5 days a week, he would get transferred over from our hospital to the other hospital for his radiation therapy. And once in a while, it would come up on my rotation, and I'd be the one that would take him. And just very quickly, in a very short span of time, you could just see the effect, not only of the disease, but also the treatment on this poor guy. And rapidly cachectic, and, rapid loss of hair and no strength, but still, fighting the fight. And it was becoming the holidays, Thanksgiving into Christmas. And I took him a Christmas card one morning before our transfer. And you could tell that really touched him.
Wow.
It was just a simple Christmas card. But, he showed me that people have a lot of fight in them. It's probably a fight I would never expose myself to if I came down with that diagnosis myself, just because I saw, and again, this was, 35 years ago.
Yeah.
Things haven't changed that much in our treatment of cancer.
Not enough.
So, but yeah, that was one I recall.
That's awesome. What a cool thing to be able. I mean, it's funny how just that little kindness on the part of the care providers can really make a huge difference for the patients. That's kind of cool. What's the best advice a nurse mentor ever gave you?
That'd probably be the woman who was in charge of the Purdue School of Nursing when I enrolled there. Her name was Linnell Geddes, and she was an awesome woman. She was a nurse. She was the head of Purdue School of Nursing. This was back in the mid-'80s when I got accepted back to nursing school. But she also had an interesting background. Her husband, who I got to know as well through some classes I took, was a biomedical engineer, one of the top guy in his field throughout the 60s and 70s and 80s, and actually got to take some classes that he taught, because I did a minor study in biomedical engineering when I was getting my nursing degree.
Wow.
And it was interesting because one of my classes for nursing, the food nutrition class, we met in some obscure building. We had Purdue University's a big campus. They squeeze in classes wherever they have classroom space. And so my foods and nutrition class took place in the building. It was called the Potter Hall of Engineering, just because that's where they had a classroom space.
Mm-hmm.
So one day I'm waiting in the hallway, sitting on the floor, waiting for class to start, and I hear this kind of squeaking wheel. I look up, and it's a surgical cart draped in green surgical drapes being pushed by a guy wearing green scrubs. But sticking out from underneath the drape is the clearly identifiable snout of the dog with an endotracheal tube sticking out of it.
Oh.
And he wheels past me and through a couple double sets of doors and disappears. I just went, well, what the heck was that? So got through class, and within the next couple of days, ran into Dr. Geddes, Linnell Geddes, the head of the nursing school, in the nursing building. I said, "Hey, Dr. Geddes, quick question." And I described what I saw, and she goes, "Oh, that's my husband's work." So he was a biomedical engineering professor at Purdue, and at the time, they did a lot of dog research of their medical stuff.
Mm-hmm.
And so I got to talking more with, the nursing Dr. Geddes. And she goes, every year they have classes where they take engineering students and life science-based people, nursing students, although more rarely, also could be qualified. They put them together in a class called basically the monitoring of physiologic events. And it teaches you what your medical monitoring devices do and how they do it. And he was, "Are you interested?" I said, "You bet I am." So she got me an interview with her husband, and I got into the class, and it was mind-blowing. The stuff I learned, not only about just physiology in general that I hadn't even realized, having been a medic and in nursing school, there was still stuff I learned from that class, but also how the machines can, but also cannot give us good data of what's happening physiologically.
Mm-hmm.
And we did all sorts of cool experiments and things on different kinds of animals, and I won't go into the gory details because it's probably going to upset some PETA friends out there. But from that, she was a mentor of breaking the mold.
Yeah.
Yeah, I was in nursing school, but hey, there's this program over here where you can take your nursing knowledge of patient care and expand on it by learning more about the physiology, the pathophysiology, but most importantly, how to monitor that physiology or pathophysiology. I mean, something as simple as blood pressure, the different, invasive and non-invasive, manual auscultatory with a stethoscope and cuff versus a non-invasive oscillometric device. What was the thing I learned most about that was like your general run-of-the-mill non-invasive automatic blood pressure. The only number that is reliable on that is the mean arterial pressure.
Really?
Because what that machine is doing is it's waiting for that largest oscillatory deflection, and that's the mean arterial pressure. And then every single one of those devices uses a patented mathematical huge derivation calculation to calculate a systolic and diastolic pressure. So even though you're getting, you put the cuff on the patient, you press the button, it cycles, 120 over 80 with a mean of, say, 88 or 90, whatever it is. The only number that's reliable on that is the mean pressure.
Huh.
The systolic diastolic is a calculated number.
I've never heard that.
So, right. And so that was just, one thing. It's like, wow, okay, cool. So
that's kind of interesting. I've never realized it was just calculated and not like captured like the way I would think of doing it.
And so, from her, she was a huge mentor of basically, follow different paths. You don't have to go this, sure, nursing school, you go from point A to point B to point C to point C and you graduate. But within that program is like, well, you can be doing this and you can be learning this simultaneously and seeing how it applies back to what you're doing as a nursing student and then what you will be doing as a nurse. So she was probably the best mentor I ever had.
Nice.
And that was the best piece of advice.
Nice.
You can step outside of the path while staying on the path.
Absolutely. What advice would you give a brand new emergency nurse?
Hang in there.
That's good advice.
Yeah. I knew a long, long time ago that emergency care, emergency nursing, this environment was where I wanted to practice. Sure, there are days it drives me crazy.
Absolutely.
There are days I wake up and go, God, I gotta go to work today.
Yeah.
But there are some days it's like, hey, I get to go to work today.
Yep.
But if you decided that that's what you want to do, I mean, there's ups and downs, there's highs, there's lows. You got to take every day as it is. There are days it's going to beat you down, and you don't want to come back. And there are some days where thing clicks, and it's like all is right with the world. Even though there's sick patients, everyone okay. So, I knew a long time ago I wanted to stay in this environment. That's why, I became a lifetime member of ENA. I mean, I joined ENA as a paramedic.
Nice.
So I knew that was the eventual path I was going to go. I wasn't going to be a medic forever. My back wouldn't take it.
Yeah.
There are some days it still doesn't, but, I knew I couldn't do that forever. I wanted to stay in that environment. And I had toyed with the idea of medical school at one point. But the interviewer from med school just pissed me off, and I said, heck with this.
That's funny.
And so I just, stayed on this pathway. And then after working as an ER nurse for a while, I wanted to have a little bit more autonomy. And that's why I went back to school to become a nurse practitioner. I wanted to be able to make some decisions on my own and, live with the consequences of those decisions. I enjoyed that.
Nice.
So I'm enjoying being a nurse practitioner. And yes, it's a collaborative practice, and I don't have a problem with that. So I have a very good physician group that I work with. They have taught me so many things over the years, and because of that, they have great trust in me. And so I take care of the STEMIs. I take care of the occasional bad traumas we get in our small community hospital. We're 30, 40 minutes away from 2 level 1 trauma centers, so we don't get a lot of bad trauma where I'm at. We get the occasional, medics couldn't stabilize. We're going to stop here briefly and move on, but we don't get a lot of bad trauma, which is one thing I do miss. But we get sick STEMIs, and we get sick sepsis patients, and we get bad strokes, and they trust me to take care of all of that.
That's awesome.
I appreciate their trust, but it's a trust that I've earned because of what they've taught me. So I'm enjoying it.
Now you posted, I don't know, at one point I remember you posting, and I remember it striking me as something that if I ever got a chance to talk to you, I was going to ask you about. You posted something about imposter syndrome. What is imposter syndrome, and what does it mean? There
are some days, and this is my, this is probably not the Webster's definition. But basically,
no, I don't. I want that. I want yours.
There are some days when you think people are going to realize I'm not as good or I'm not as smart as they think I am. And it's all going to come crashing down. And there are a lot of days I still feel that way. It's just like, there are just some days I feel like, you don't really know all this. You just act like you do. And I don't think that's really true. I mean, I don't think I could have gotten this far by faking it.
Yeah.
But there are just still some days when you think, and I think a lot of it comes from not being able to take praise well.
Yeah.
People compliment you on something, and it's just like, oh, well, no, don't say anything. And so you get that praise, and then it kind of messes with your head. And then you start thinking, well, I mean, people are praising you for this or for that or for knowing this or for doing that, but I'm really not as good as they think I am.
Yeah.
That starts to kind of gnaw at you a little bit.
Yeah.
I think I'm good at what I do. I'm certainly not the best at what I do. There are people out there who are smarter and more skilled and can think on their feet faster, but I still think I'm okay at what I do.
I bet. I think that When you posted it one time on Facebook, and I remember seeing it and thinking to myself, I'm glad I'm not the only one who's experienced that. Because there's been times in my career where I've thought for sure, like I'm going, what are you doing? What are you doing? Get ready to get up on the stage and tell these people about whatever. You don't know this.
Right.
You don't know this better than everyone else in the room. What are you doing? And it messes with your head.
Well, it's kind of how I felt at National ENA in St. Louis in 2017. I was scheduled to give 2 talks. One was on a case study of aortic dissection in a pregnant patient, but the other was a talk on novel therapies for refractory VFib, specifically dual sequential defibrillation and esmolol therapy.
Uh-huh.
And, I got accepted. I'm going to give the talk. No big deal. I've given the talks before in other forums. Just kind of to tweak it, make it, a little bit more nice for, the national audience.
Yeah.
And 2 days before I show up to St. Louis, I get this email from ENA saying, hey, we've decided for your dual sequential defibrillation esmolol talk, we're going to put you in the big room and we're going to live stream it. So not only are all the people at ENA in St. Louis going to be able to watch you, but people at home can log in live. And it's like, what the fuck? 2 days before you're going to spring this on me?
No pressure.
So it's like, okay, so, I'm driving from Indiana to St. Louis, with this weighing on my mind. And I get there the day before, and I got, so I'm going to the prep room, to make sure everything's just how I want it. I made a few tweaks, got the final version uploaded to the IT people there, and, went and checked out this monstrosity of a room that I'm going to be talking in. It's like, oh my God, what have I got myself into here?
It's almost better not to.
Yeah. And so I thought, the day before was when there was like a gathering the evening before when Jeff Solheim had Alex Wubbles, the nurse who stood up for the drunk patient, and got arrested.
Yeah.
Yeah. So she was a surprised, special guest at ENA that year. So everyone was crazy about Alex Wubbles. Oh, she's here. Everyone's getting selfies with her and pictures with her and all that cool stuff. She did a great thing for emergency nurses, and it was wonderful. So I decided I'm going to open up my talk in front of hundreds of potentially not thousands of people with a joke, because that always breaks the ice so well. And so I get introduced. I get up on stage in front of this, the biggest room in the convention center. And of course, you can't see who's there because you're all blinded by the light and it's dark out there.
Of course. That's a good thing.
So I said, hey, I want to welcome everybody to ENA 2017 in St. Louis, or just now being referred to as the Alex Wubbles Love Fest.
Oh, no.
And there was like fucking crickets in the room. Like, wow, that didn't go over as well as I had hoped.
Oh, no. She was in the audience, wasn't she?
I don't know. I mean, it wasn't a slam against her at all. I thought it was she did a great thing. She did the right thing, and she stood up for her patient, and, she did everything right. And it was great that she was at ENA. And I was just kind of poking fun at the fact that everyone was like going wild crazy over her. And it was great. She needed that moment, but I probably took it the wrong way.
That's funny.
It was like, oh, well, you try to be funny. Sometimes your humor bites you in the ass. And that only just can further contribute. Then I'm going to crash and burn on this stage no matter what I say.
Oh, I'm sure you did fine. But boy, that's it's always hard when you like put something out there and you're like, hey, this is kind of funny. And then you're like, that didn't really go over that well.
I've got a very dark, sick, sarcastic sense of humor, and
I like that.
Some days that just doesn't work out so well.
Yeah, I like that about you.
I mean, I gave a talk last year at one of our local trauma centers. I got invited to speak at their annual trauma conference, and I spoke about intentional and accidental hanging injuries. So I've had a few good case studies that I incorporated, but I so badly wanted to use the video clip from Blazing Saddles where he says, they said you was hung, and Cleveland says they was right. And the nurse I worked with and loved to death at the trauma center, she goes, no, you can't use that.
She's like, no.
Said, yeah, I guess you're right. But damn, it really does fit my talk very, very well.
That's funny. That's really funny. One of the first national nursing conferences that I did the CES conference one year. And I look out into the audience. I'm getting set up, and it's usually like a who's who of ENA. We have different ENA board members there. The
right.
Current president was there at the time, and I'm getting ready to do a lecture on stroke, which I knew real well. And I was like, getting ready to do this lecture, and I look into the audience, and I have the president of ENA in the audience. I'm sitting there going, okay, that's a little intimidating. But then Gene Prale comes in and sits into the audience, and I'm sitting there thinking to myself,
there you go.
Okay, what am I going to teach Gene Prale about? What am I going to teach Gene Prale about anything with emergency nursing? I'm like, she wrote the book on emergency nursing. I mean,
right.
I was like,
right.
Holy cow. And I was sitting there, I was so intimidated by that. I remember doing my presentation going, oh Lord, let's see how this goes. Did the presentation, it went fine. And she, I got a chance to meet her afterwards and went up and she came up and introduced herself and said hello. And it was awesome. She was fantastic. She was so lovely. And it, wasn't near the pressure I thought it was going to be. But sure enough, it was a little intimidating at first.
Oh yeah. Yeah, I've had those moments myself where you look out there and it's like, oh, what are they doing here?
Yeah, you're like, okay, well, all right. That's funny. So the last question I have is a question I'm going to ask everybody, and this one's kind of a hard one. But the last question is a question that I like to call 3 things, and it's the 3 things that an emergency nurse should always remember, and 3 things an emergency nurse should just go ahead and forget.
Yeah, I mean, I guess, one could be flip and just say, don't forget to eat, don't forget to pee, and don't forget to chart what you did.
Pretty good advice.
Remember to always remember to do those 3 things. If you got the opportunity to do the first 2, take it, and always do the third.
Yeah.
Things to forget. Shoot. Now you got some tough questions here, man.
I know this.
So don't forget why you chose nursing. Certainly no one chose nursing because you're going to be driving a Ferrari or live in a mansion. You went in nursing to help people, so don't forget that's why you went into nursing.
Yep.
And always, do your best every day to help people to the best of what you're able to do. And that might be limited by resources or what you can do at your hospital or the competence of the provider leading the care, and they're going down the wrong path. Don't forget why you went into nursing, and take that to your bedside every single day. Don't forget that and I said this recently, spontaneously at a nursing symposium at my alma mater at Purdue. Don't forget that there is honor and pride in being a bedside clinical registered nurse.
Absolutely.
There seems to be this mindset now, and it's being placed in the nursing students' minds by the schools, that you should no longer be satisfied with being a registered nurse. You need to be an advanced practice nurse. And this conference I went to, it's our annual school conference that they have every year. It's called the Helen R. Johnson Nursing Leadership Conference. She was the founder of Purdue School of Nursing. This year's theme was, are you ready for a master's degree or a doctorate in nursing practice or a PhD? Then you go for it right now without any experience of being a nurse. And I listened to that for about 45 minutes. It was a panel discussion of recent nursing school and advanced practice school graduates. And I stood up in the back of the room with about 300 people, and I said, this is wrong. There's honor and pride in being a bedside registered nurse. I loved being a nurse. There were reasons I went on to become an advanced practice nurse. Those are my personal reasons. But to be told by a nursing school and to be told by a nursing organization that the only reason school is a stepping stone to become an advanced practice nurse is wrong.
Absolutely.
We need nurses. The only reason hospitals exist is because nurses are there to take care of patients who can't do what they need to do for themselves. That's what nursing is about. We're taking care of patients. The hospital is a building that puts all of those factors in one convenient place. But the patient is always going to need a nurse.
Nursing care.
And there should not be the mandate that nursing school is only there to serve as a stepping stool to become something else. I went to nursing school with absolutely no thought in my mind ever that I would do anything beyond that. I was going to nursing school because I wanted to be a nurse. And it was only about 13, 14 years later that I said, I still enjoy this and I can still do this. But at that time, I wanted to do something more. And that's why I went back to school. Okay? But it wasn't with a thought in mind that I walked into my freshman first day of nursing school and says, yeah, this will do for now, but it's because I'm on my way to this. And that should never be the mindset.
Yeah,
if you want to become an advanced practice provider, go to PA school.
Yeah.
Don't waste your time getting your nursing degree because you're not going to have the clinical experience as a nursing student to go right into a master's or a DNP program and come out on the other side and be competent to take care of patients. If you want to go a rapid path, go to PA school because you're going to get that clinical experience in a more professional format. If you want to become an advanced practice provider and do things like that, go to PA school or go to med school. Don't go to nursing school with a thought in mind that it's a stepping stone to something else just because for that reason. So don't forget, we need nurses. And that's why you became a nurse.
Absolutely.
Thirdly, I'm going to get lambasted for that section. I can tell you that right now, but that's okay.
I don't think you will, because I think, so many schools out here in Houston are really pushing the, what I jokingly call 0 to hero. You go from they're taking brand new nurses with absolutely no experience and putting them into NP programs. And I was like, that was never I don't think that was ever the thought. Like, they're going to get out and they're not going to have any life experience. They're not going to have any nursing experience. They don't have that mental Rolodex of patients that they've seen. They're not going to recognize those patterns that they're seeing as a nurse practitioner that isn't as a long time bedside nurse, stretcher side nurse would see. It's crazy.
Well, and you gave the example in our talks here today, your nurse colleague who had never seen anaphylaxis before.
Yeah.
It's what if she or he went on to become an advanced practice nurse and had never seen anaphylaxis before?
And it's funny. She was in NP school. She was in NP school at the time, and I was just like, "Holy cow!" And you're right. I'd never made that connection, but you're absolutely right. And there's something to be said for being a bedside nurse and being a stretcher side nurse. That you're right. There is honor in that.
And then finally, thirdly, third thing that I don't forget is, and I fail at this miserably, but I try to tell myself almost every day, you get to leave work at work.
Yeah, it's hard.
Yeah, you work an 8, a 10, most likely a 12-hour shift, and you never get out on time, and it's busy, it's stressful, you're short-staffed, you feel administration doesn't have your side. The patient's always right, no matter how wrong they are.
Yep.
Don't forget to try and leave all of that crap at the door as you leave the ER. And go home and divest yourself of all that. And I say this with complete honesty, I fail at that miserably.
Yeah.
But that's what we need to try to do. Yeah. It's okay to say, I'm not saying it's wrong to go home and say, could today have been a better day? How can I fix this? It's okay to try and fix the problem, but don't let it consume your outside of work life, as so many of us, me included, seem to do.
Yeah.
Worry about things, fret about things, dwell on things, try to figure out things. give yourself some time to break away from that environment and enjoy what you've got.
Absolutely. It's hard to, when I was a director, it was hard to. I wasn't allowed to leave work at work. I mean, I was on call 24/7, and if the phone rang, I had to pick it up. And in my new role, where if when I'm off, I'm off. I don't check my phone. I'm not checking my work email. I don't check my work email when I'm off for days. But it still doesn't mean I'm not wondering how things are going. Still doesn't mean that I'm not wondering, where are we? Do we get the beds emptied? What happened to that patient that was coming? It's hard sometimes to take it out of work and leave it there.
Right.
I can't even imagine for a practitioner. It's got to be, I would imagine I would go home every day just kind of going, did I make the right call there?
Oh, yeah. That's why I say I fail miserably at this advice.
Yeah, it's hard. That's got to be one of the hardest things in all of nursing. It's got to the idea that there's patients that you'll never forget, and sometimes you won't forget the ones from last night versus ones that you wake up thinking about from years ago.
Yeah,
a lot of old ghosts sometimes, I bet.
A lot of old ghosts.
So, again, thank you so much for spending so much time with me. I really appreciate it.
You're welcome.
I really enjoyed this conversation. This has been a lot of fun.
Hopefully we'll meet up in Austin. I'm not going to make any promises, but I'm going to try and get there, but we'll see if we can cross paths there.
Well, if you come, I'd love to hang out with you and say hello, and I hope you do make it.
All right. Looking forward to it.
Okay, man. I'll talk to you soon.
All right. See you, Kevin. Thank you.
Thanks. Talk to you later. Bye.
Bye.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.